My apologies, though I think perhaps no apology is needed, for the slight delay to the start this morning. As you will hear when the panel start to speak, there is what one might describe as something of a Scottish accent to it, and a flight from Scotland, as some of you who are here will know, was delayed this morning in arrival. It emphasises the difficulties in scheduling an event such as this, particularly with very busy and prominent experts who are also at the moment heavily engaged in fighting the COVID-19 virus and considering its consequences for us. Ms. Richards, may they be sworn?
So yes, we're having a slight technical issue behind us with an echo, which is very disconcerting and is going to have to be switched off. So perhaps Mary can do the honours. Oh, great. I think it's just been switched off with the socket, which makes life much easier.
Please state your full name. Take the book in your raised hand and repeat after me. I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
Catherine Joanna Mary Jeffery.
And take the book in your raised hand and repeat after me. I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
Scott Jamieson.
And take the book in your raised hand and repeat after me. I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
Aileen Elizabeth Marshall.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
Graham Stephen Cooke.
Take the book in your raised hand and repeat after me. I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Can I ask you to start by introducing yourselves and saying a little about yourselves, perhaps starting with you, Professor Cooke, and then working your way down the table?
I'm Graham Cooke. I've worked in the care of patients with HIV and hepatitis for over 25 years, and I'm currently based at St Mary's Hospital in London. There I lead the HIV hepatitis service, but the majority of my time now is spent on research, and my research focuses particularly on new hepatitis C treatments and how they work, but also how we improve access to those treatments both within the UK and internationally.
Okay. I'm Aileen Marshall. I'm a hepatology consultant and I'm based at the Royal Free Hospital in London. It is a centre for specialist treatments for liver diseases, and so most of my time is spent in the care of patients who have complications of chronic liver diseases or acute and sudden liver diseases. So the main aspects of this would be liver transplantation, primary liver cancers and autoimmune hepatitis.
Hi there, I'm Scott Jamieson. I'm a GP up in Kirriemuir in Scotland. I also have a role within the Royal College of General Practitioners in Scotland. I'm the Executive Officer for Quality Improvement in Scotland. I have a strong interest in improving the quality of services across Scotland and the clusters, and improving detection and treatments, access to hepatitis treatments in Scotland as well.
My name is Katie Jeffery. I'm based at the John Radcliffe Hospital in Oxford. I divide my time, I work in 100% clinically. My time is divided between being a laboratory microbiologist and virologist, working as an infection consultant, seeing patients with a broad variety of infections, but I also have 20 years of experience of working in the viral hepatitis clinic, looking after patients with both hepatitis B and hepatitis C. I also work as the Director of Infection Prevention and Control for Oxford University Hospitals.
I'm John Dillon. I'm Professor of Hepatology and Gastroenterology at the University of Dundee, and I'm a consultant hepatologist and gastroenterologist at Nine Wells Hospital in Dundee. I lead the clinical hepatitis and bloodborne virus services for NHS Tayside, and I have spent 30 years researching various aspects of hepatitis C and clinical liver diseases.
Thank you. The report which you produced was co-authored by you and by a number of other experts who are not here today, but whose names are detailed and qualifications detailed in the report. It's my understanding that there are no significant areas of disagreement amongst those who contributed to the report about its content. Is that right?
That's correct.
And your report's been produced in response to 2 letters of instruction, and you've sought to address the questions in both the original and the second letter of instruction in this report. So there's no further report currently expected or awaited.
That's correct.
Can I start by asking you to address some fairly basic concepts? First of all, what is hepatitis and what is viral hepatitis?
Well, maybe I'll start and then others will come in, I think. So in the first section of the report, we've outlined this very briefly, and I think it's important because people use the term hepatitis in different ways, both as doctors and as patients and others. I think when we talk about hepatitis, we try to be precise in the report, and in general terms, we're talking about hepatitis meaning inflammation of the liver. And the most common way that that's picked up is with blood tests. So often we'll do a set of blood tests which will include liver function tests, and these are some specific tests which look at evidence of inflammation in the liver, and one which I expect we'll come back to in particular is ALT. And there are levels of what we expect to be normal in a normal patient, and we define hepatitis when those are outside of those normal ranges, and there is various discussion about what normal ranges should be. So viral hepatitis in that sense doesn't tell you the cause of that hepatitis in that sense doesn't tell you the cause of that. And there are many different causes of hepatitis, some of which are infection. And amongst infections, some of those are viral infections. And those will be obviously the focus of much of what we talk about today. But hepatitis can be caused by drugs, it can be caused by fat in the liver, it can be caused by genetic conditions, it can be caused by metabolic conditions. So there's a very wide range of causes. And often the assessment of hepatitis is trying to work out, both from questions and tests, which of those causes is likely to be the main issue. So within the viral infectious causes of hepatitis, we have 5 main viruses, A, B, C, D, and E. And hepatitis B and hepatitis C as chronic viruses will be the focus of this. Globally, the majority of, sort of 95% of viral hepatitis and the problems related to it comes from those 2 particular viruses. So in the report, we haven't really dealt with hepatitis A and E.
No, and I'm not going to ask you to deal with those today. I will ask you to deal a little with hepatitis D and with hepatitis G at a later stage. Again, dealing with some of the basics, how does inflammation of the liver, hepatitis, result from exposure to viruses? What's the mechanism that causes that inflammation?
So if the cellular processes are disrupted by the virus is a parasite. It uses the cell's own replication systems to replicate itself. And so as it does that, it disrupts the normal function of the cell. The different viruses do things in different ways, but they will change protein production. That will lead to damage in the cells. They can increase the amount of damaging toxins that are produced in the cell and cause damage to the cells. Ideally, the virus doesn't want to destroy the cell because it wants to carry on using the cell to replicate more of itself, but viruses aren't clever, so they can sometimes damage the cells. The chronic viruses tend to be better at maintaining a better relationship with the cell, so hepatitis B and C are sometimes less damaging in the short term, which allows them to replicate chronically or better at evading the immune system, and whereas the A and E viruses are more damaging acutely but are cleared away by the immune system. And the virus itself can damage the cell, or else the immune response to clearing the virus can be the process that damages the cell. So it's that 2 separate processes. It can be directly from the virus. Hepatitis B is perhaps more damaging to the hepatocyte than hepatitis C is, but the immune response can be more damaging, which is why some people have much more florid illnesses than other people when they're infected with the same virus, and it depends on the immune response to those viruses.
You mentioned ALT and AST levels, and I think we've heard quite a lot of evidence from individuals looking at their records, seeing test results that relate to these. So it would be very useful, I think, for our communal understanding for you to explain what is meant by AST and ALT levels, what the significance of raised levels is, and what that can tell us about the condition of the liver.
So ALT and AST are two enzymes that they're representative of a vast number of enzymes that live within the hepatocyte. Okay, and they have particular cellular functions, but they are particularly focused in the liver. The ALT more so than the AST. The AST can also appear quite commonly in muscles. And when those cells are broken down and turned over, those enzymes leak out into the bloodstream, and we can measure them in the bloodstream. If there is more damage to the liver cells than normal, more of that ALT and AST will appear in the bloodstream and will show that hepatocytes are being damaged, that more hepatocytes are dying and being damaged that day than the previous days when the values were lower.
And it's probably just worth emphasising that you can see those raised levels of those enzymes in the blood, and the patient may have no symptoms. And equally, you can have someone who's quite unwell where the abnormalities are not that dramatically different. So when we're talking about the tests, we tend to call it a biochemical hepatitis with the evidence from these enzymes to distinguish it from what we might call a clinical hepatitis when a patient has symptoms which might involve tenderness over the liver, for example.
And just to follow up, these abnormalities are very, very common. 20% of all liver blood tests measured have an abnormality of their ALT levels. And so they are very common from a multitude of causes that Professor Cooke alluded to in his opening statements.
So is this right? And if it's not, please correct me. Raised ALT or AST levels will not themselves be diagnostic of hepatitis B or C, but they may be an indication that further investigation, including the diagnostic tests that we'll come on to, will be required.
Yes. Absolutely.
And is there any correlation between those raised levels and the condition of the liver in terms of fibrosis or cirrhosis?
No. If I can perhaps explain.
Yes.
So if you think of the liver, it's about 1.5 kilos, and if there's 10% of that turning over in a day, then that's how high your ALT will be. If over years you've lost 2/3 of that liver and you only have 500 grams left, the natural turnover of the ALT will be much lower because there'll be less of it to escape into the serum. And therefore you'd have to have a lot more damage for it to raise the levels, and so it doesn't correlate. And with the hepatocytes that die, it's a question of whether they die and are replaced by new hepatocytes, which is what happens most of the time, or whether they die and are replaced by scarring and fibrosis, which then leads to chronic damage and the fibrosis and cirrhosis that we'll get on to talk about later.
Yeah. Okay, thank you. And if I can just ask you to touch, again by way of introduction, on hepatitis D. Our understanding from your report is that hepatitis D, sometimes referred to as Delta virus, only infects those who already have hepatitis B, and perhaps you could just outline that for us.
That's right. And so the terminology is used interchangeably sometimes, so hepatitis D, Delta virus, HDV as well. But on its own, hepatitis D isn't able to replicate and produce new virus. It relies on the presence of hepatitis B and what that does to the cell for it to be able to replicate. And it may infect patients who already have hepatitis B, and there are many examples of that, or particularly in the setting of blood transfusion, perhaps it might be at the same time, and there are documented cases of that. And it's only able to maintain its replication after that point. So I think in terms of patients affected, we see that what we would call hepatitis B delta co-infection as a subset of hepatitis B overall.
And we asked you, I think, in one of the supplemental questions, a specific question about hepatitis G. Can I just ask you, again, by way of introduction, just to tell us what hepatitis G is and what its significance is?
Katie, do you want to? I'll just so hepatitis G was associated with co-infection, particularly with HIV in the early stages, and there was a suggestion that it would have influenced the progression of HIV, and so and then there is an increased prevalence of hepatitis G in the setting of HIV in particular.
And it was uncovered around the time of the discovery of hepatitis C. We discovered the hepatitis G genotype as well. We thought it was our next hepatitis, but we haven't found a significant clinical illness associated with hepatitis G. It appears that it can live in the liver, but it doesn't seem to cause much damage, and it seems to be quite common in the population. So it seems to be a commensal rather than a disease at the moment.
Now, you've set out in your report in a little more detail then information about the viruses, and I'm going to focus for present purposes on hepatitis B and hepatitis C, and may ask you a little more about hepatitis D later. You tell us in the report that hepatitis B is a DNA virus, and there's a distinction between that and hepatitis C, which is an RNA virus. Could you explain what those differences are? So DNA would be familiar to people from common parlance, but deoxynucleic ribonucleic acid is different from ribonucleic acid, and in general, RNA can be converted into DNA, and so these are different chemical types of entity that are different between the viruses. And I think it's one example highlighting how, although there are many similarities between the viruses, they actually fundamentally are very different viruses and behave in specifically different ways. DNA clearly is part of what our human body has in its cells, and that DNA then produces RNA as a message to the cell to make proteins. For example, hepatitis B can integrate into that DNA in a cell, and that we'll come back to later is related to ability to clear the virus. Whereas RNA viruses don't, well, hepatitis C doesn't do that, and that's an important distinction between the two. Others may want to add other aspects of that. Yeah. In relation to hepatitis B, you've told us in the report there are 8 recognised genotypes, and those are identified as A through to H. You've explained in the report that the clinical relevance of those genotypes is limited in contrast with hepatitis C. Could you just again explain shortly why the different genotypes have relatively little clinical significance for hepatitis B?
So I think it's difficult to explain why they don't have a lot of difference. One of the things to say is that there's a very wide geographic distribution of these different genotypes, and obviously if you want to ask the question about anything about whether A is different from B, you need to have studies where you can have groups of patients in a similar setting, where you can look at how those different viruses behave in a similar population and tease out differences. And there are relatively few big studies able to do that in different parts of the world. So you need an area where there's a lot of patients who have different genotypes within that. So it may be that there are things that we don't know, but in general, there have been relatively few studies which have shown a difference in a particular population, and we've mentioned 1 or 2 examples where there has been a suggestion in the report.
Your report explains, however, that there are pathogenic differences between the genotypes in relation to hepatitis B, and that those differences can explain progression to liver cirrhosis and to liver cancer. Could you elaborate?
So there are some examples, for example, suggesting that maybe genotype C could be associated with a more aggressive course of liver disease than genotype B. But in general, there isn't a big enough difference that that's a very useful part of a discussion with a patient or in planning management of a patient. But I mean, there is one exception, which is potentially in relation to response to interferon. So although interferon was always historically really used for hepatitis C treatment, there's a small area of use still in hepatitis B, and some genotypes may respond differently in terms of their response to interferon. But that's, it's a relatively small part of practice for hepatitis B.
And in the United Kingdom, genotype D, I think, is the most common in hepatitis B.
So I would think it would be fair to say we don't have great information on the distribution of genotypes in the UK, and I think both for B and C, this is a reflection on both transmissions within the UK, but also migrant populations moving in and out of the UK from areas of very high prevalence. And so what we have seen, and there was one fairly large study which tried to look at this, is a number of different genotypes, but genotype D would seem to be one of the more common ones, but it's not the majority. There are others that are present.
And then in relation to hepatitis D, before we move on to hepatitis C, your report indicates that it's around 3% of those in the United Kingdom with hepatitis B will also have hepatitis D. Hepatitis D itself has 8 genotypes, but there's limited data available on any clinical significance of those genotypes. Is that right?
Absolutely, and we looked quite hard to try and find the best data we could from the UK, and others may have found some more, but there isn't very good data to tell us. But I think as an overall view, and remember that we're talking about everybody with hepatitis B from all causes of infection, we think the prevalence is probably around 3%, and we don't have very much data at all on which genotypes are more common. And again, in terms of the relevance of genotype in the setting to a patient and the patient's management, it's relatively less important to know what that genotype would be, although there are potentially some exceptions. And then we're getting into quite small print about...
Professor Dillon.
Can I? So in terms of that rate of delta infection, it's only in people who have been infected with hepatitis B and have become chronic carriers of the surface antigen. So it's that combination. So it's a much smaller set of dolls, if you like, of Russian dolls in terms of the number of patients that are actually affected.
Now, hepatitis C, which you've explained is an RNA virus, has 8 genotypes, and then in excess of 80 subtypes. And we'll look at the genotypes in a little more detail in a moment, but could you just tell us what subtypes are?
Katie, do you want to take that one?
So one of the things that we talk about also is quasi-species and the subtypes. So RNA viruses, when they multiply, they don't replicate faithfully. You don't get exactly the same genetic makeup of the RNA every time. And a lot of the time that doesn't matter, but sometimes it introduces subtle changes. And that is how historically the genotypes have arisen, and then there are sort of further sub-branches of the genotypes. So within each genotype, there may be subtypes. So for example, within genotype 1, we have 2 big subtypes, 1A and 1B, but there are other further subtypes. So it's almost like a family tree where you start out with genotype 1 and then different species, subtypes, as the virus evolves.
And in the United Kingdom, it's genotypes 1 and 3 that account for some 40% of hepatitis C infections. Is that right?
Each, yeah. So I think that so genotype 1 remains just about the most common. And I think one of the things that's a little bit different in the UK from perhaps some other similar Northern European countries is we have a relatively high proportion of genotype 3 infection, and that in some ways reflects migration back and forth to the Indian subcontinent. And if people have the report, in figure 15.2, we try to illustrate how different genotypes distribute across the world.
We'll just put that on screen. I think it'd be easier for those people to follow. So it's EXPG 601, I think. Page 5, it should be, Henry.
And so I think, if I may, just to make the point that I think we had a lot of supplemental questions about hepatitis C genotypes, and clearly both from a patient perspective and a decision-making perspective about treatment, genotypes have been a really important part of that discussion for a long time, and that's changing, and we can talk about that a little bit, but there are very clear differences both in the genotypes and some of those subgenotypes that Dr. Jeffery mentioned. So I think that's obviously been a greater focus in terms of trying to describe that.
And we've got the figure up on screen. It should be on screen in front of you. Could you perhaps just talk us through what it shows us?
So I think what this figure is trying to show is to illustrate 2 things, really. So each of these pies, if you like, is proportionate in size to the numbers of patients we think have been exposed to hepatitis C in different parts of the world, in terms of numbers. So you can see, obviously, very large numbers in Indian subcontinent and Southeast Asia, and substantial numbers in many parts of the world. And then we've tried to estimate and colour code each of those pies according to which genotypes are most common in those areas. So you can see, if you look at the European chart as a whole, red being genotype 1 is the most common. And as I mentioned, the UK is slightly different from that because of the green area, genotype 3 being a bit bigger. And if you look at India and the Indian subcontinent, you can see very much dominated by genotype 3. That's part of the explanation. Overall, in the world, we would say about 45% of hepatitis C is due to genotype 1, based on the estimates we have.
Do we have an estimate of the numbers of people in the UK who are infected with hepatitis C?
That's a kind of important question that I don't want to give a very specific answer to, and John may do that. But I think the good thing is that that's a dynamic number, because things are changing very quickly at the moment. And I think there's an important distinction in all these numbers about patients who have antibodies, and I think this is an issue that's come up in a lot of the testimony, and we heard on Monday again, the difference between patients who have antibodies who may or may not actually still harbour the virus, and people who actually have the virus or would be viremic, as we would say. And often the estimates that we've had historically have been based on antibody tests and exposure, whereas I think at the moment we're having a greater focus on the numbers of patients who remain with virus and need treatment. So broadly speaking, I think the figure for the UK that I last saw was about 210,000 patients with antibody prevalence, about 160,000 in England, and that's changing. But proportion of that number who still have virus is obviously diminishing quite rapidly with the rollout of treatment. And you might want to comment on the numbers, John, in terms of Scotland and where things are.
I think things have changed over the 20 years, 30 years. It depends on how much monitoring we do, and we don't have perfect monitoring. We don't screen everybody in the country for hepatitis C, so we don't know precisely, but from the estimates and the studies. We thought back in 2006, 2007, that perhaps 1% of the Scottish population, about 50,000 people, were infected. About 0.5% of the English population were infected, and a proportion of that. What's happened over time is those numbers have come down. So Scotland is now probably around 21,000 people left with the virus. That's both those that know they have the virus and those that don't know they have the virus. And a similar proportion in Scotland, and that's the effect of both treatment, death with the virus, and new people not becoming infected, because if we think of the prevalent cases, it's dependent on all three of those things, and so that's a dynamic number. And with the new treatments that have become available, that number is shifting downwards very rapidly, and with both England and Scotland and Wales being committed to elimination, that number will continue to fall rapidly in the next couple of years, so it's a dynamic number.
And then sticking, if we can, with genotypes, because there were a number of supplemental questions asked of you in relation to genotypes. Is there any information about the prevalence of particular genotypes amongst those who were infected in the United Kingdom through transfusion of blood or blood products? Has that been the subject of research or study, as far as you know?
So there is data. We weren't asked that question, so we haven't provided that data. I mean, we could provide that data if that's helpful.
We might ask you to do that. I've been asked to ask that question by core participants, which is why I've raised it.
If I can, so the genotype won't identify your route of transmission reliably. While you are more likely to be genotype 1 if you were infected through a blood transfusion, you could equally be genotype 2, 3, 4, or 5, and if you didn't acquire it through another route, proportions may change slightly, but they will vary more geographically than they will by route of infection. So it's not a reliable, there's not an absolute rule that if you've got this genotype, it must have come from a blood transfusion or from some other route. So the genotype isn't useful in predicting that.
And you've said in the report it's not known if certain genotypes are more likely to be associated with spontaneous clearance of the virus.
Yeah, so just for sort of context then, a large number of patients who get infected with hepatitis C can clear that virus without any treatment. And it sort of goes back to the question of, it doesn't necessarily mean it isn't an effect, but it's hard to get data to show that effect. There is some suggestion in some settings, for example, that genotype 1 may have a slightly higher clearance rate, particularly in patients who've got HIV, based on some studies. But there isn't a lot of comparative data because it's not a very common problem to study.
And in terms of progression to liver damage, liver disease, cancer, what data, if any, exists about the significance of the genotype in relation to that?
So the evidence is not perfect, but there is a suggestion that genotype 3 is more likely to progress more rapidly. Not vastly more rapidly, but that a higher proportion of patients with genotype 3 than, say, genotype 1 would have cirrhosis at each time point that you followed them up for. And so there does seem to be that effect. That was counterbalanced because of the early introduction of treatment was more effective in genotype 3 than genotype 1, and so it became difficult to do the studies to work out the natural history because people weren't being left untreated.
If I may, it's probably helpful just to pause for a moment with genotype 3, because as John was saying, it can cause a bit of confusion that when in the era of treatment for hepatitis C, genotype 3 was referred to, and I think many people won't like this phrase, but it was referred to as easier to treat. Now, for people who've had 6 months of interferon, that won't necessarily be easy to treat, but it was comparatively higher cure rates for interferon therapy for genotype 3 compared to genotype 1, for example. And as we may come back to later, in the current era of treatment, actually, it's probably a little bit harder to treat genotype 3 than genotype 1. So I think when people talk about easy and hard, it becomes a little bit more confusing. So genotype 3 has clearly changed in its relative ease of treatment over time.
And it's possible, as I understand it from your report, to be infected with more than one genotype, but typically someone will have a dominant genotype.
Yes,
Is that right?
and I think we put a section in about that, and I think that was one of the supplemental questions. And I think so there's a number of issues. So if you are infected with hepatitis C, whether or not you're cleared or cured, that doesn't give you the same level of protection that a vaccination might do. So it's possible to be reinfected after you're treated, but that also means that if you have an active infection, you can get an active infection on top. And the older tests for detecting genotype would tend not to detect all of that difference in virus. They tend to detect the more common one. And so you'd often just get one of those reported. And what we can see more clearly now with modern techniques in genetic sequencing that others are better qualified to talk about is that we can see the relative proportions of different viruses a patient may harbour. And I think there is evidence clearly that patients infected with multiple exposures can have different genotypes within one person, and we can come on to the relevance of that if that's helpful. I don't know if anybody wants to add to the.
I think just to add to the relevance of that was that in the past, when we had treatments that were, if say genotype 3 appeared to be the genotype that the person was infected with, if they were treated with the shortened courses of treatment that we were using at that stage for genotype 3, we might then see a genotype 1 infection appear because we'd cured the genotype 3, but the genotype 1 had appeared. So that was the problem back then. With the modern therapies, that becomes less of an issue because they're very effective against all genotypes.
So we were asked a specific question about whether having multiple genotype infections was associated with a worse outcome. And so we looked quite hard to find that data. Now, we didn't find clear data to show that, and that's not to say that that's not the case. It's just that we weren't able to find the evidence to show that. But I think we can know from first principles that there are potential risks there, and I think John's highlighted one of the main ones there, which is that you may get inappropriate, you may not get the treatment you would have had otherwise if it had been known that you had these other genotypes.
And does exposure to multiple genotypes, or having multiple genotypes, make spontaneous clearance less likely?
I'm not aware of evidence of that. I think it's unusual to be exposed to more than one at the same time.
You've explained in your report that both hepatitis B and hepatitis C are viruses at least now known to have been around for several thousand years. And the figures you've given in your report is hepatitis B has been found in human remains up to 4,500 years old, and that it's estimated that hepatitis C first emerged over 3,000 years ago. But it's in the last 100 years that both viruses have spread geographically. And that's due, in particular, I think you identified, to migration and geographical factors. Is that right?
Katie,
Yeah.
Okay. Yes, I mean that's correct. I think it was difficult to find in the literature evidence going beyond those number of thousands of years, but they probably have been around for a very significant amount of time, and obviously we'll never get a clear date on that, but they have both been around for thousands of years. and they have spread more widely around the world in recent years. And of course, we have the ability to diagnose them now, so we've become much more aware of them.
Now, in section 15.3 of your report, you were asked by the inquiry to provide a short history, a short chronology. And Professor Cooke, you're going to talk us through that a little, but with a number of qualifications. First of all, we've asked you to focus on current knowledge and understanding, not the question of what was known by whom or what should have been known by whom and when. And this is not intended by any stretch of the imagination to be comprehensive or exhaustive. And in particular, I'm not going to ask you to address the questions that might arise in relation to the second half of the 80s and early 90s about whether things could have been done earlier, should have been done earlier in relation to non-A, non-B hepatitis, hepatitis C. So with all those qualifications, because those are matters of fact which the inquiry is investigating for itself, determination by Sir Brian on the basis of a very wide range of contemporaneous materials that we haven't provided to you, could I ask you just to talk us through some elements of some milestones in the emergence of that informs modern science?
Yeah, certainly. So the question as it was put to us is as it's in the report, and I think we had a lot of discussion as to how we would best present this, and in the end we felt that this was probably quite a helpful way to present a chronology. You'll notice tomorrow as well that we've tried to harmonise this a little bit with the HIV chronology as well, so we haven't dealt with a lot of other things that may be relevant, particularly from HIV, in this list. And obviously the first point is where do you start? And I think although we've chosen the discovery of hepatitis B as the point to start, clearly it was recognised before that for decades that hepatitis existed as we've described it already, and that there were different forms of hepatitis. There was what was then called infectious hepatitis, which we now know to be hepatitis A, and then serum hepatitis, which we now determine as hepatitis B. So really the beginning of the era of understanding hepatitis better began with that discovery of what was first called Australia antigen and we now call hepatitis B surface antigen. And I think just to make a general point about dates, we've put a date in here which references a paper that reported it. But I think there's a general issue about when was something actually discovered that we haven't really gone into, and this is probably more relevant for other things later. But clearly, although a paper comes out at a certain point, there's a process before that where knowledge is evolving and being shared, and that then leads finally to a public presentation. So we've just chosen a date we can reference. But obviously, once a virus is discovered, and hepatitis B in that case in the mid-60s, that then leads to the ability to develop a diagnostic test, and I'm sure we'll come on to that in more detail. And those tests were introduced in the UK in the 1970s. And as you say, we've been deliberately non-specific about the precise dates because we understand the inquiry will look at that in more detail, both for hepatitis B and hepatitis C. But once tests are available, that allows surveillance. It allows a structure from a public health perspective to go into place, which happened during the 1970s for hepatitis B. And of course, at that time, it was then possible to distinguish patients who had biochemical hepatitis who didn't test positive for hepatitis A, the virus for which was discovered in the early 1970s, or hepatitis B, and that's where this term non-A, non-B hepatitis developed until the discovery of hepatitis C. So really we see through that first period the understanding, an improved understanding of non-A, non-B hepatitis, an introduction of hepatitis B vaccination for those at risk, and obviously in the background of an emerging HIV epidemic. That was really important, and I think that for the diagnostic side of things, the discovery of hepatitis C as the main cause of non-A, non-B hepatitis was crucial at the end of the 1980s, and then led to the ability to introduce tests very rapidly that could be used to diagnose that with initially antibody-based tests, which we can come back to. So then after that period, we then see sort of what we might characterise as a sort of developing field of hepatitis in terms of treatment in particular through the early 90s, and better reporting with the ability to detect both hepatitis B and hepatitis C by this stage, and more international recognition of the challenge of viral hepatitis, and introduction of various committees and public health bodies that were focused on trying to address that, with some treatment available, largely with interferon at that point. And it was really in the later 90s, at the same time that HIV treatment was developing, that specific treatments for hepatitis B and C became more commonplace. And so The first what we would call directly acting treatment for hepatitis B with lamivudine in 1998, an HIV drug, and subsequently other drugs that we can come on to, helped to manage a group of patients with chronic hepatitis B. And at the same time, we were seeing improvements, although it's an improvement from a low base in terms of interferon treatment, both with the addition of pegylated interferon, which could be given less frequently, with some improvement in side effect profiles and better cure rates, and the combination of that with ribavirin through the 90s, which then allowed a sort of growing evidence base around how best to manage and treat hepatitis C and hepatitis B, but hepatitis C in particular developing through that phase. And to the point where sort of around the turn of the millennium, there was a much greater public health focus on what needed to be done to both prevent and treat viral hepatitis B and C in particular. And we've listed a number of key sort of events in terms of creating bodies and structures that allowed that to happen. And I think we saw in the first decade of this millennium an increasing international awareness of the importance of viral hepatitis and more international involvement, which led to more investment, until the point about 5 years ago now where there was really a transformation driven by the changes in hepatitis C treatment, which really were transformative in terms of what that meant for medicine. And it's one of the sort of the biggest areas of medicine as a whole that's changed in the last decade. It transformed the ambition of what people had towards viral hepatitis as a whole, both nationally and internationally. And we've seen since then very ambitious international targets for the elimination of viral hepatitis, with funding in some cases following that, and very much more ambitious programs throughout the home nations in terms of trying to address hepatitis C in particular, but also more recently scaling up hepatitis B vaccination, for example, and other aspects of tackling viral hepatitis. So I think that's hopefully a kind of broad overview without going through the individual points, but we can go back to individual points if those help.
And in setting out that overview, you weren't asked to, and you haven't drawn any conclusions one way or another about the adequacy or otherwise of measures that were taken or not taken, whether things could have been done earlier or should have been done earlier, because that's not the exercise you've been asked to do. And so it's important that what you've set out there is understood in that context.
That's correct. And also, we've tried to reference dates where we can objectively do that. And I think it's important to recognise that even around treatment introduction, there may be practice that's different from those dates. And so we wouldn't want that to be sort of taken too rigidly.
Now, I want to move to the question of how blood-borne viral hepatitis, how hepatitis B and hepatitis C are transmitted. And you've dealt with that in section 15.5 of your report. You first identified transfusion of blood and blood products as a means of transmission, and obviously that's the focus of the inquiry's work. And you've set out an explanation of current screening measures in relation to blood donation. And I'm not going to ask you to deal with that in any more detail. Again, in particular, the historic position in that regard is going to be a central part of the inquiry's later hearings. But there is just one question that I wanted to ask, being picked up by a number of core participants. It's page 9 of your report, and it's in the section which gives a narrative overview of the current practice in relation to screening and testing of blood donations. You've picked up in the second paragraph this, data from SHOT, and SHOT is serious hazards of transfusion, demonstrate that there's not been a confirmed case of transfusion-transmitted HCV in the UK since 1997, and 1 confirmed and 2 probable cases of transfusion-transmitted HBV in the last 10 years. Now, that's something that I think some core participants have been particularly interested to see, but it's something that you're not able to shed any further light on, and it's a question that needs to be directed to JPAC as to, do you have any more information about those cases, given the dates of them?
So I think I would say that one of the experts our main expert in this area is not here, and I think I'd be reluctant to go too much further, but I don't know if others have more insight as to that.
I suspect from a confidentiality perspective in general, if with numbers such as small as that, I don't know how much more detail you would be given on that because of risk of identifying them. They're such unique cases, so I'm sure that they would do that with due prudence to the confidentiality of the individuals who are unfortunately involved in that. But I'm sure the details from the JPAC guys would be able to give you more interest.
The shock report itself, I think, doesn't give any more information than is recorded
and I
here.
think that's probably for that reason. Usually, in these kind of things, that's sometimes for those kind of reasons.
So my understanding is that the problem was a system failure within the laboratory testing, that the test was performed but didn't detect the positive virus for whatever reason. Now, whether that was there was concern about the quality of control of the testing and dates, etc. But it's a reflection of if you've got tens of thousands of tests being done, there is always the potential for one of the tests not to function as it's supposed to and expected to test. So that's that was the likely outcome that was associated with that. But it's the constant quality control and audit process that they are constantly checking and back checking all of their processes, and the fact that the hundreds of thousands of tests have only failed on that small number of occasions is reassuring.
We'll thank you for that, and we'll perhaps direct those queries elsewhere to see if we can find out any more about that information. The other routes of transmission, for the sake of completeness, that you've identified in your report, first of all, mother to child, what's often referred to as vertical transmission, that can occur in both hepatitis B and hepatitis C.
Mm-hmm.
And that can occur both during pregnancy and around the time of delivery.
Yes.
Breastfeeding does not transmit hepatitis B or C, as I understand it, unless there's significant skin damage, skin breakage. Is that right?
Sorry.
Sorry, yes.
Yes, certainly. I'll just go. So transmission of both hepatitis B and hepatitis C can occur vertically from mother to child during pregnancy and around the time of delivery. Is that correct?
Yes.
Thank you. Breastfeeding, by contrast, is not a route of transmission in either hepatitis B or hepatitis C unless there is clear breakage to the skin and bleeding.
Yes.
Can I just understand, while we're on this section of your report, how, or that my understanding of the percentages quoted is correct? You say at the bottom of page 9 that up to 40% of transmission of HBV is before the onset of labour, and you say, quote, 30%, I think, for HCV. Mm-hmm. That is of those cases which are transmitted vertically, is it?
Yes.
I thought that was clear, but I thought, would I make it clear?
And then, again, in this section of the report, you've gone on to talk about horizontal transmission between children. And I wonder if you could, although it's not a significant area of focus for the inquiry, again, so that we can understand all routes of transmission, could you just explain briefly what that refers to?
Yes, so this is particularly an issue for hepatitis B, and it's really a well-recognised issue in low-resource countries, particularly high-prevalence countries in Western Africa, where it's been very well described, of hepatitis B negative children becoming positive during childhood, presumed by contact with other hepatitis B positive children, although we don't really know fully that means of transmission. And it's important to emphasise that we're in an era where hepatitis B vaccination, even in the poorest countries, is being scaled up very substantially, and that's becoming a less of an issue. But it is nonetheless still an important mode of transmission, but less so in our own setting, I think.
And you've explained that infants infected in early life are much more likely to develop long-term chronic infection than adults. First of all, is that true both for hepatitis B and hepatitis C, or is it just one?
So it's well described for hepatitis B, and I think it's generally an important issue to understand in that at the younger ages, the likelihood of becoming a chronic infection is higher. Maybe as high as 90%, as opposed to when you get infected in adulthood, where that might be as low as 25%. So quite a big difference, and that has long-term implications for the health of an individual infected. In terms of hepatitis C, it's a little bit less clear-cut. I don't know.
Yeah, I don't think there's clear evidence. I mean, the rate of chronic infection is already high, and we don't have sufficient cases to measure how much higher it is.
The next route of transmission that you've identified is transmission through contaminated needles and syringes. And that's not just recreational drug use, that can be medical use, tattoos and piercings. And that's more common with hepatitis C than hepatitis B, is that right?
Yes.
And then lastly, sexual transmission. And there are important distinctions between hepatitis B and hepatitis C in this respect. And perhaps I could ask one of you to just identify what those differences are.
Well, I'll start and I'll let others come in. I think obviously one of the key differences is the availability of vaccination. So for an individual at risk of infection, there is an effective vaccination, hepatitis B, which can reduce the risk of transmission in all ways, but sexual transmission in particular. But without that, and with an infectious partner, there is quite a significant risk of sexual transmission from hepatitis B, and we still see cases, particularly in adults, of sexual transmission of hepatitis B. For hepatitis C, and I realise this is an issue of particular concern to many people, then there are good estimates of what the transmission risk of hepatitis C is, and we know it's very, very low, but it's not zero. And obviously this can be an issue in terms of messaging to a patient what that means, and we'll talk probably tomorrow a little bit more detail about HIV, where we're moving to an environment now with HIV where if you're suppressed on treatment, we can give patients very clear messages to say you're not infectious. And there are studies to show that the risk is as close to zero as we can estimate it to be. And with hepatitis C, that risk is very, very low in heterosexual transmission. I know that's an issue that we'll probably come back to. And we've put an estimate in the report of what we think that rate is based on the published literature. It's worth making the point that we do see sexual transmission at the moment, particularly for men who have sex with men. And we're seeing quite a lot of transmission of hepatitis C in that way. So that's a different nature of sexual activity, which is probably associated with a higher risk of transmission, probably to do with what happens to the mucosa. So in general, we can say within heterosexual sexual activity, then the risk is very, very low. But in other forms of sexual activity, it may be different.
And the figures you've given, because not everyone will have read the report, but it is an important issue. You've put it this way: sexual transmission of HCV between heterosexual couples is rare, estimated at 0.07% per year, or 1 in 190,000 occurrences of intercourse.
And I think the general issue is that trying to produce a single figure that covers all eventualities is difficult, and I think that doesn't necessarily mean that applies to an individual.
Can I then come on to ask you about diagnosis? And I've noted the time, sir, and I know how much you like the breaks to be on time after yesterday.
Good moment.
It's another topic and not a particularly quick one, so perhaps this would be a convenient point at which.
Well, in that case, this would be a convenient point. Shall we say 12 o'clock? Yes.
So the next topic I want to ask you about is about the diagnostic testing. And can I ask you, first of all, just to give an overview, absolutely as you've done in the report, but a summary of the distinction between the assays, the EIAs, and then the what you've described as the NATS tests, and what their different functions are, please.
Okay, so the majority of diagnosis is done by what we call enzyme immunoassay. And in general, they are looking actually at the body's response to the virus, so the body's immune response, which produces antibody. But in fact, for both hepatitis B and hepatitis C, there are also enzyme immunoassays that have been designed to look at protein components directly of the virus, which is very helpful. And the best example of that is hepatitis B surface antigen, which is a surface protein of the virus. Enzyme immunoassays have been around for a long time. They've been used certainly for diagnosing hepatitis B from the 1970s. And they are very much what we would call the workhorse for diagnosis. For both hepatitis B and hepatitis C, we're often not making the diagnosis in the acute phase of the infection, in the early period after the first contact with the virus. So these assays are very good at picking up what we call prevalent infection or chronic infection, looking at either protein components of the virus or the immune response to the virus. The NAT assays that we're talking about, or you may hear about them as PCR assays or virus load assays, those are actually looking directly at the DNA or the RNA of the virus, and we heard Professor Cooke talk about that earlier. So those assays are looking in general after someone has got a positive reaction on one of our EIA assays, and they're used to characterize whether that person actually has active infection, certainly in the case of hepatitis C, because we've also heard it's possible to completely clear the virus. So for hepatitis C, we use them to define if someone has active infection, and we use them to define whether treatment has also been successful. For hepatitis B, we use viral load type assays to work out the phase of somebody's infection and also to guide us on treatment and to whether that treatment is working. So they're complementary, and together we use them to get a picture of somebody's stage of disease, of where they're at, just in terms of their virology. They don't tell us anything about the actual pathology going on in the liver. They are purely diagnostic assays and assays that we're using to help us guide treatment.
So it will be through other techniques that the presence of cirrhosis or fibrosis will be detected, and we'll come on to that later.
Yes.
But these techniques will tell a clinician and a patient if the patient has or has had hepatitis B or hepatitis C.
That's correct.
You've used the phrase about the infection being active, and I've been asked by some to ask you to explain exactly what's meant by the infection being active.
So from my point of view, if we look at the diagnostic tests, and if I just deal first of all with hepatitis C, what I mean about the infection being active is in fact that our RNA test, our virus load test, shows that there's detectable virus in the body. And it's as simple as that, really, because a significant percentage of individuals will clear the virus spontaneously, so they will have positive antibody tests as evidence that their body, the immune system, has seen the virus at some point. But when we use our viral load test, we won't find any virus. And of course, an individual who's had a successful treatment, again, we won't be finding any virus. So active infection for hepatitis C, just from the purely diagnostic point of view, is easy to define. It's the presence or absence of whether there's RNA. For hepatitis B, that is a different way of looking at things. active infection in terms of hepatitis B is most easily defined as whether or not you have hepatitis B surface antigen. Because it is perfectly possible to control the virus with your immune system very well, such that you have undetectable viral load, but you still have active hepatitis B infection.
You've talked in your report in relation to hepatitis B diagnosis about the window periods. And could you please explain what's meant and understood by that and what its significance has been and now currently is?
So the usual definition of a window period is that period of time between when you are infected and potentially and when the diagnostic tests become positive. For hepatitis B, that's actually quite a long period of time, maybe even up to a couple of months, but sometimes shorter. So it is possible that before diagnostic tests become positive, potentially to be infectious, as the virus level initially will be very low. In general, if you were to be able to test somebody daily after they'd been infected with hepatitis B, the first thing you would probably pick up would be some hepatitis B DNA using one of our molecular assays. But in a very short period of time, a very short delay, you would also pick up hepatitis B surface antigen. That is usually taken as being our earliest marker of hepatitis B. Theoretically, there has historically much has been made of a sort of second window period when an individual clears hepatitis B, which, as we've said, is quite common if you acquire hepatitis B as an adult. You lose your hepatitis B surface antigen, so you lose the main marker of having infection. But you may not become completely negative on your virus load. You may still have some low-level virus before your immune system fully kicks in and gets rid of that last bit of virus. So there is a potential for a second window period, but as our diagnostic tests have got much, much better, that, I think, has really gone away as a major concern.
And what about hepatitis C? Do window periods have any particular significance in relation to hepatitis C?
Not in terms of the diagnostics, no. But again, there is a window period whereby the usual diagnostic tests that we're using, which would be detection of hepatitis C surface antibody, do lag behind the virus load test. So again, if you were to test somebody daily who had just been infected with hepatitis C, the first test that would become positive would be the hepatitis C RNA test, and then the hepatitis C antibody test would become positive later. And in fact, if we know that somebody has been at risk of hepatitis C infection, the particular setting that I deal with quite frequently would be potentially a needle stick or other exposure in the healthcare setting. We would actually do hepatitis C RNA tests first to make sure that we could identify that individual as soon as possible.
And in relation to hepatitis C and the kind of window period that you've described, what's its magnitude?
For hepatitis C RNA, in general, you would expect to pick that up within a couple of weeks after infection, and then the antibody can sometimes lag a little bit. It may be a week or two later.
In terms of the criteria for testing for hepatitis B, you've explained in your report that there will be two approaches to the decision to test for hepatitis B. One might be because an individual presents with clinical features that could be consistent with the condition, and so a clinician ought to arrange tests. And the second is if they meet an indication for screening. And you've listed in your report the NICE guidelines for hepatitis B screening. Am I right in understanding that the NICE guidelines in relation to hepatitis B don't include those who have received a blood transfusion or blood products as an at-risk group, in contrast with the guidelines in relation to hepatitis C? So we've got the guidelines for hepatitis B screening, the bottom of page 15 and top of page 16 of the report, and they don't include that cohort. But hepatitis C, they do.
As long as I have transcribed that correctly, that is the case, yes.
The rationale for
Yes.
that is because hepatitis B testing for blood transfusion dates back to the 1970s. The chances of anyone having had a blood transfusion that would then be Hep B positive would be infinitesimally small, whereas for hepatitis C, clearly anyone transfused before 1991 or blood products before 1987 would be at risk. So it's the age of the populations, and the guidelines for screening are written on the basis of cost effectiveness rather than risk of detection alone.
I think it might just be worth emphasising one other point before we go on, which is about how these tests developed in time. So most of the first tests were based, as we were hearing, on the presence of an antibody, and it was later that the tests were developed that could detect virus directly and were introduced later. So in relation to window periods, then that changed over time, and the development of those later tests was able to narrow the window periods. And I think that's probably relevant for a number of questions.
And again, a question I've been asked to ask is whether it's possible to have a rough timeline of the introduction of the different generations of tests. I'm not asking you to do it on the hoof today, but is that information that you would be able to provide to the inquiry?
It was something that I did try to provide, and I found it quite difficult to find the actual evidence. And clearly, individual diagnostic laboratories. So these tests have been described, as you may well have heard, as having as sort of generations. So, and it's similar for HIV. So certainly for hepatitis C, we've got called the first generation tests, second generation tests, third generation tests, and they may have been introduced at slightly different rates in slightly different places. And I did find it difficult to find accurate dates. I have, where I could find them, put that in. We could look again if you would like us to try and narrow that window down a little bit further.
Okay, thank you. Yes.
I might add, just for clarity, I suppose, that as much as we've divided it into the two groups, the ones with symptoms and the higher risk groups, there are public campaigns to try and obviously increase the visibility of the issue with regards to those who've had blood transfusions in the past, but moreover with regards to increasing professionals in a general practice setting, I suppose I would suggest, with regards to our awareness of being mindful of minor changes in liver function testing to prompt the change. So they might not have symptoms, but that GPs should be are now even more acutely reminded of that. And we have developed systems in Scotland now which will be national within this year, developed based on research of Professor Dillon, that we will be automatically far more proactive about that. So this is an evolving area, more than the two distinct groups, which is somebody coming in jaundiced and somebody who's a high risk. There is a third area where, in order to deliver the national policy agreements with regards to elimination of Hep C, that we need to be more proactive. It's not just about the screening at-risk groups, nor those with symptoms. There is another population that we're readily identifying. We have intimated that and referenced Professor Dillon's work, which was started from our area in Tayside and in GP. It's done in general practice, and that's been rolled out now across Scotland. So it's a great innovation, but is if you want to eliminate Hep C, you're not going to do it just with looking at the high risk groups and those with symptoms. There is this other cohort that we are picking up through that, and we do have patients that we're picking up through that change. But this is an evolving area.
Thank you, and I'm certainly going to come back after lunch to the position in relation to general practice, because as I know you're aware and you've heard some of the evidence, particularly the evidence given in Edinburgh, delays in GPs arranging for tests for hepatitis C has been a common theme in a lot of the evidence we've heard. Just then turning to hepatitis C, you've identified in your report, and I'm looking for those who have the report at the top of page 17, that in the mid-70s, it was clear there were cases of hepatitis occurring post-transfusion attributable to neither hepatitis A nor hepatitis B, hence the term non-A, non-B hepatitis. Now, again, I'm not going to ask you about the details of the developments in relation to knowledge of non-A, non-B and what should have been known or what was, as a matter of fact, known by clinicians. But is this fair? What was being recognised as non-A, non-B is what we now term hepatitis C.
So the almost all non-A, non-B hepatitis was hepatitis C. Yep. So we were in the situation in the early 1970s where we could test for hepatitis B. There were patients who were receiving a blood transfusion and they were still getting what had been described as serum hepatitis. We knew it wasn't hepatitis B because their tests were negative. It was about 30%, I think, at the time of those patients. The disease appeared to be milder than the hepatitis B-related ones that we'd seen before and seemed to be self-limiting at that time was our understanding, but we knew it wasn't hepatitis B. Those patients were put into cohorts and followed up for from the 1970s onwards to see what happened to them. And it was in the late 1980s those cohorts started to notice an increased incidence of liver disease. And when the hepatitis C virus was discovered, the tests were applied to those cohorts, and about 80 to 90% of them were hepatitis C positive. The other hepatitis that have been noticed, as we alluded to at the very start of the inquiry, there are lots of things that can cause an inflammation of the liver, and when patients are having blood transfusions, they're having them because they're ill for multiple different reasons, and so there are other causes for hepatitis amongst them. But the majority of the disease that we called non-A, non-B hepatitis was hepatitis C.
Thank you. And there's one issue you've alluded to there that I'm not going to ask you further about, but I'm just going to explain why, which is the question of whether it's correct to say that non-A, non-B was regarded as something that was mild and self-limiting. Again, that's a very important area of factual investigation for the inquiry as to what was or should have been understood about non-A, non-B in the 70s, from the 70s onwards.
Can we just establish, as a matter of known fact, so far as fact is known today, that a significant proportion of those, the natural history is that a significant proportion of those who come into contact with blood which carries the virus of hepatitis C will themselves develop an infection of hepatitis C. You're nodding.
Yes, I'm agreeing with you.
That of those who develop that infection, some will clear, but the others will remain chronically infected. What sort of proportion clear?
So approximately 20%. It varies on perhaps the dose and perhaps on other factors about the person themselves, but roughly 20% will clear spontaneously and 80% will carry the virus long term.
So 4 out of 5 develop chronic infection. Yeah. And in your report, you quote that the rate of development from chronic infection to cirrhosis, unless it's treated, is between 1 and 2% per year.
So we quote the rate at 1 or 2% per year. It is probably not a linear increase, and so that the risk of cirrhosis in the first couple of years is virtually zero because you've got the fibrosis accumulating, and then it becomes much steeper as you become older. So rather than it being a straight line of 1 or 2% per year, it averages out at 1 or 2% per year over a 20 or 30 year time frame, but many more people will develop the problem in the later time period.
So after 20 years, you say that 30%, or roughly 1 in 3, of those who have been infected will develop cirrhosis.
Indeed.
It will follow that after 40 years it will be 60%. And I think that after that you haven't got the figures.
We're still, those cohorts are still being followed up, and clearly, depending on the age of infection, the cohorts get smaller and smaller.
But there may be some, for instance, those who had transfusions at an early age, very early age, because they suffered from haemophilia, transfusions in the sense that they received blood products.
Yes.
Who might have been in contact with hepatitis C, of whom, therefore, it would follow that, following the natural progression, 4 out of 5 would have chronic infection, and after 40 years, 2/3 at least would be suffering from cirrhosis.
Yes.
And what proportion of those who have cirrhosis develop cancer?
So the rate of cancer development, the literature, the field and the knowledge has changed recently. For those with a definite diagnosis of cirrhosis, the rate of conversion to the development of cancer is probably up to 4% per year. It depends on cofactors. Being male is more likely to push you forward for cancer than female. Other cofactors such as obesity and alcohol intake will also accelerate that rate potentially. But it's about between 2 and 4% per year. But the more advanced your liver disease becomes, the higher the risk. So again, it's not a straight line. The risk increases exponentially for the longer that you've been cirrhotic.
So that is per year. So if we take, suppose we had someone who after 20 years of chronic infection developed cirrhosis, after another 10 years they would have had, on those figures, a 30 to 40% chance of developing cancer unless there was treatment.
Yes.
I think that's reasonable. I think we have to be slightly careful to remember that we're looking at populations here and trying to produce numbers related to a population, whereas when you're having a discussion with a patient and what the patient wants to know is what's going to happen to them, and that's not the same. And that is obviously one of the difficult issues of communication, and Aileen may want to come in on this.
There was one point I wanted to make earlier about your comment about the duration of infection and the relationship with age. So many people who were exposed to blood products will have a longer duration of infection, but there was an indication that people who are exposed to hepatitis C at an older age, that the older they are, the more susceptible the liver is to damage, and that those patients infected at an older age had a more rapid progression to liver fibrosis and cirrhosis. There's also a strong relationship with age and liver cancer, independent of cirrhosis or not cirrhosis.
Thank you.
And just a final point from me. I mean, I think we may be coming back to this in more detail, but I think it's important to recognise that there are, as we've heard, a wide range of factors for an individual which modify that risk of progression. And we've listed a number of those in the report. But that does create a wide variability for an individual in terms of how quickly they may progress, both to getting cirrhosis or not, and getting cancer or not.
And if I could make just one further point about the different viruses, the combination of hepatitis B and hepatitis D is the virus that's associated with the higher risk of both the development of cirrhosis, the development of liver failure, and of liver cancer.
Thank you.
There's just one point of clarification I wanted to ask, arising out of what you've set out in your report about diagnosis and testing, which you've set out in some detail, and so I'm not going to ask you to go through the details of it. But if we look at towards the top of page 20 of the report, to the second paragraph, it's a short one, so I'll just read it out. It says, over the last 2 decades, 96 to 2017, there's been a more than 8-fold increase in the number of laboratory reports of HCV, positive HCV antibody and or HCV RNA in England. And again, a question that's been asked me to ask you is, do we know what the explanation is for that 8-fold increase?
Yes.
Thank you.
So that's because we've managed to educate doctors and nurses and the public to do the test, to ask for the test, and it reflects a vast increase in the number of tests being performed.
And perhaps we could just put the figure on screen, because sometimes seeing the document. Thank you, Henry. You're ahead of me. So we see it there, the chart which maps out that increase.
And I would think, in the past 3 years, that sort of pattern of increase will be continuing. It will be, in particular, with the strategies, the national strategies we've already alluded to.
Can I then, before we leave the question of testing and look at symptoms, can I just ask about the reliability of the tests? Your report alludes to issues in relation to false negatives and false positives. Again, you've gone into it in some detail in the report, but could you perhaps summarise for us what the position is, in particular in relation to current generation of testing and false positives and false negatives?
So this is a really important concept around diagnostic tests. So we describe diagnostic tests in terms of their sensitivity, and the sensitivity is the proportion of people who have the disease in question who will be diagnosed by that test. So we're looking for tests that have 100% sensitivity. And the situation that we're in with our current enzyme immunoassays is that we're very, very close to 100% sensitivity. And some studies report 100% sensitivity. And that's what we're looking for. In fact, that is a major priority. We want to pick up everybody who may have the disease that we're looking for, and we actually don't mind it as a diagnostic person. I don't mind if it even says somebody has the disease who doesn't, because before I'm going to report that test, have ways of working out whether that is a true positive result or not. Now, the other big concept in terms of diagnostic testing is specificity. So that is not creating false positives. I might just go back to where I talk about that to make sure I get the phrase here absolutely right, because these are quite tricky concepts to understand, even though I'm dealing with them all the time. So a test with 100% specificity correctly identifies all those without the condition of interest. So again, we're looking for that to be close to 100%, and the current diagnostic tests are very close to 100%. It does depend what population you're looking at, and in general, the rate of positivity of diagnostic tests for hepatitis B and hepatitis C in routine diagnostic labs is very low. So we're asking a lot of our tests. It's quite unusual on a daily basis in my laboratory to have somebody with a newly positive test. So we are looking at, in fact, I believe, current tests. They're very, very good in that they are picking out the right people. As we've discussed, there are a number of supplementary tests that we do to ensure that we're giving the individual the right diagnosis and that we haven't generated false positive information or missed an important diagnosis.
You say in the report, and this is in the bottom half of page 21, that about false negatives. Reasons for a false negative result include patients with acute HCV infection before the antibody has appeared, which we've already alluded to. And then there's persons with major immunosuppression, advanced HIV infection or organ transplantation recipients, and persons with chronic renal failure on long-term hemodialysis. What systems or processes exist to try and ensure that those false negatives don't result in diagnosis being missed in individual patients?
So it's a really important question. So these false negatives relate to individuals who produce poor antibody responses. It is a difficult issue. We would want to be using our PCR virus load-based assays to try and pick up those individuals. And certainly around renal dialysis programs, transplant programs, we are doing a number of assays that are virus load-based to pick up the virus rather than looking for antibody responses.
So this will often be an issue that the clinician needs to think about and be recognising that we're dealing with a situation where there may be a poor antibody response, and recognise that that's an issue, and then actively do a test that they may not otherwise have done to look directly for the virus. And
moreover, we would be screening for these prior to transplant and prior to hemodialysis, as part of routine before you get to the point where you're going to cause immune suppression, providing there's not then